hızlıca stabilleyin. Gereksiz radyolojik tetkikler istemeyin. Siz de vakıfsınızdır. Günlük pratiğimizde de öyle oluyor. İlk basamakta çekilen tomografileri biz genelde zaten üst düzeyde çalıştığımız için genelde ikinci basamakta tekrarlıyoruz. İstememek lazım. Değil mi? Gönderen doktorun bir takım sorumlulukları var hastanın gidişinde ya da kabul eden doktorun bir takım sorumlulukları var. Bunlar neler olabilir? Gönderen doktorun sorumlulukları. Ayça Hocam.
Hastanın gelişini, bu arada neleri yaptığımızı, hangi tedavileri
Kesinlikle
verdiğimizi,
tüm bilgileri iletmemiz lazım karşı tarafa.
Medikasyonları,
Evet.
yaptığımız medikasyonları
Aynen.
yaptıysak kan transfüzyonu ya da kan ürünlerini mutlaka belirtmemiz lazım. Transfer sırasında götürecek olan ekibin neye
Kesinlikle
ihtiyacı
transport
olduğunu
modunu ve tedaviyi devam
ve tedavide neleri
söylemek
vermesi
lazım, değil mi?
gerektiğini, hastayı niçin gönderdiğimi, hastadan
Endikasyonu.
bir üst basamaktan ne beklediğimi, beklentimin ne olduğunu ve tedavisinde tabii yönlendirici olması şartıyla neye ihtiyacı olduğunu belirtmekte fayda var.
Çok teşekkür ederim. Kesinlikle bunları söylemek lazım. Bununla beraber ne yapacağız? Gelir gelmez hemen sevk etmiyoruz. Hastayı ilk önce stabillememiz lazım, değil mi? Karşı tarafla iletişime geçmek ve 112'yi de haber vermek lazım. Alıcı doktorun da bir takım sorumlulukları var. Hastayı değerlendirecek. Hastanemin kapasitesi buna uygun mu değil mi? Buna yardımcı olacak. Eğer hastayı alamıyorsa da hastanın başka bir yer bulması noktasında sevk eden hekime yardımcı olmak zorunda. Hasta birinci basamağa gitti. Level 1 travma merkezinde. Burada yeniden değerlendirildi. A'sı B'si normal ama C'sinde kalp hızı yükseliyor. Kan basıncı düşüyor. CT çektik. Orta düzeyde bir splenik yaralanması var. Aynı zamanda pelviste kompleks bir kırığı var. Direkt grafide de sol femurda fraktürü var. Bu slaytın vurguladığı nokta işte benim de söylediğim gibi ilk basamakta bunu çekmediniz. İkinci basamağa gitti. Daha ileri merkeze gitti. Bu yaralanmalar var ama siz hata yapmadınız. Normal olan, doğru olan ilk basamakta CT'yi almamaktı. Zaten bu hastayı sevk edeceksiniz yukarı merkeze. Maalesef bunları kafa bilekli konuşacağız. Soru ve katkıları. Sanırım objektiflere ulaştım. Köy Learning Points'te tekrar etmekte yarar var. Eğer hastanın ihtiyacı kapasitesini açıyorsa mutlaka sevk etmeniz lazım. Sevki hızlandırmanız lazım mutlaka. Ve gereksiz tetkik istememek lazım sevk öncesi. Teşekkür ediyorum.
Evet, bütün hocalarımıza ben çok teşekkür ediyorum. Katıldığınız için size de teşekkür ediyorum. Aslında bir çekiliş yapacaktım. Çıkana ATLS kursu ücretsiz olacaktı ama vazgeçtik şimdi. Başka bir zaman çekiliş yapalım. Öyle değil mi Mustafa Hocam? Zamanımızı da açtığımız için soru cevabı arada alabiliriz. Hepinize katılımlarınızdan dolayı çok teşekkür ediyorum. Ara veriyoruz. Sağ olun. Evet, aradan sonra bir oturumumuz daha var.
Test, test. Ok, ça marche.
Emre.
Normalde onun bir tane olması lazım. Attılar mı? Faut que tu appuies pour parler. Ouais, mais moi, tu vois, il est...
Test.
Ok. Hello, from Maya.
Yeah, hello.
Okay, happy to see you here.
Thank you.
We must begin. Okay, From Maya begin his presentation. He is the director of International Medical Service at the Vitos Xanit International Hospital in Malaga. And I invite you to begin, Dr. Maya.
Okay, I don't know if you loaded the presentation in the system.
The sound is not too...
Now the sound
Okay.
is better now?
They are working. Okay.
Okay. So they are working on downloading the presentation.
Okay.
Okay.
It's-
Yeah.
Thank you to be here. You have a very difficult situation now. We have learned.
Yeah, yeah. I mean,
How are you?
Things are going better, fortunately. And well, I think my dad is coming out of the hospital, I think, soon.
Yes, yes, we have
and
heard. Okay.
Yeah. Okay, very, very happy to be.
How is
to be
your
online.
dad?
Yeah, he's fine. He's fine. He's getting better.
Okay.
Yeah,
Okay,
yeah.
super.
Yeah. So yeah. Um,
We hope
Merhaba.
we hope to see you next year in May, perhaps.
Yeah, yeah, yeah. I mean, anytime if nothing like this happens, I mean, I will be happy to see you at all. So, yeah, yeah, no problem.
Yes, we're waiting you, Dr. Moya. Okay.
Yeah, thank you.
They are
Yeah.
preparing the sound. Okay.
Yeah, and I think they are down. I mean, I've been informed by the WhatsApp that they are downloading the presentation as we speak.
Okay. A few minutes.
Yeah.
Okay. Dr. Maya, how many years are you working in emergency medicine?
Well, I mean, our hospital is a private hospital. We see about 80,000 patients per year. I mean, that's the pre-pandemic, obviously. And we are usually, all our doctors are senior doctors. We don't have residents being a private hospital. So obviously, it's different from a public health hospital in which you have residents and so on. So we are about four doctors in the morning, four doctors in the evening, and two doctors in the night, 24 hours, 365. And we have also two consultant pediatricians because the pediatric emergencies are divided in Spain and the pediatricians specialize in pediatric emergency care run the department. So apart from 4 and 2 emergency physicians all the time, I mean, with the standard of consultant, we have two consultant pediatricians most of the time on the other side. Okay, I think I got control now of the presentation. I mean, I don't know.
Thank you. Emre, it's okay? We can begin? Okay. Okay.
Yeah. Yeah, I think. Let me see if I can.
The sound, please. It's okay?
Yeah.
Okay.
Yeah, we can start. I mean,
yes, you can start. We are listening to you. Okay.
Yeah, but I cannot scroll down the presentation. That's the only thing. Yeah, now. I think we can now. Yeah, definitely. So we'll start. I mean, merhaba everyone, and thank you, IPAD, for inviting me to participate even online, and always to invite me to a lot of projects and congresses and conferences. So thanks to everyone, especially to Professor Kander and all of you guys. I would like before to think for everyone involved in emergency medicine to think about what we do now in emergency medicine and how busy our emergency medicine departments are and whatever. I'm going to present a project called Smart Art that we develop. I mean, it's been developed mainly in the UK by a colleague of mine called Dr. Anjin Mohamed, that he runs the emergency department in Doncaster. And that's where this project is been proven and it's been tried for the last 4 years. So I would like all the audience to have an open mind It's a very, I got a lot of slides, but I know that we are restricted in time, so I'll try to make it as fast as possible. I only want to share the concept because this is something that probably we will need a conference in itself. If you have any questions or you are interested more in this project, you can always contact me or Dr. Mohammed in the UK. And then if you want more info, we will be happy to share it with you. So obviously emergency medicine now is a global problem, not only in the developed world, also in the low middle income countries, because we are increasing the demands every year. We have limited resources, and there are a lot of implications, health, financial, and political. The concept of the Smart ER project is we have to understand what the downtime is in the emergency department and elsewhere, that we want a Smart ER. I mean, we had the idea that the patient has to be the center of the process. This Smart ER works better when we have an increase of activity. That is, a bit strange when we are talking about emergency medicine, because it seems like increasing activity is always worse. We think that increasing activity for us is better because the machine engineers everything better, that the patients are part of the solution, that we not only look at the in-reach care, which is where when the patient is in the emergency department, also the system looks at the outreach care. We try to bring order versus the chaos that usually is and usually happens in the emergency departments. And we believe in the major emergence of emergency medicine. Things have to change. Obviously, we need a change. We need to innovate. We need to be modern. We have to embrace technology. Obviously, if we center the process into a patient, that will lead us to have a patient-centered care. We have to rethink the relationships between the patients and us. The pressure is not only because of the blockage of the emergency departments in the exit. Also, when people come to emergency department with low acuity attendances, and I think that happens in every emergency department in the world. The challenge, I mean, I think there is a format problem with the slide, but anyway, I don't know, you can see that. I will tell you that the emergency departments are the most utilized services in acute, the most utilized department in acute services. Just to give you a figure, that usually nearly half of the population, between 35 and 50% of the population of every nation attend the emergency department in 1 year. So in a country like ours in Spain, that we have a population of approximately 40 million, 42 million people, nearly half of that people, so we're talking about 20 million people come to the emergency department nationwide in our country. There is a variable demand, and we know that. We don't have a lot of technology to support us. I mean, it's very variable, the technology that we use in the emergency departments. We have electronic health records, we don't. So we need and require solutions that perform well under high demands. We think that the care doesn't have to stop when the patient leaves. It's got to be a continuity of care when the patient goes. We have to have a measurable follow-up. Obviously, I think with the technology and with all the things that we have at our disposal, we need digital health solutions. We provide InReach, with which we want the patient to engage while he is in the department, and the outreach, which is we need to follow up this patient where they live. So obviously we are talking about innovation, development, and improvement. We try to think ahead for these things. Obviously, we develop this depending on where we are now and we are going to be in a few years. So we know that it's going to be an increase of demands, increased morbidity. The patients are changing. The patients are more pluripathological. The patients, keep living longer. And obviously they got more expectations. There is a problem with the staffing. I mean, you asked me how many staff we have. It's a problem worldwide. We haven't got enough doctors, enough nurses to attend the population at the moment. Obviously, there's a worry about the cost, the value for money, how efficient we are, and obviously social and IT changes. And that the last one is NHS strategies, because obviously this presentation and this system is working in a national health system hospital in the UK. I can. There is something in the format of this slide anyway when we pass it there, but this slide only show that there have been some strategies in the UK in the national health system, some projects to try to implement technology and digital workforce in the system. So as long as 2011, they started thinking about how they could do it. But now, I mean, that was obviously a thing for the future, but where are we now? What do we do in the emergency departments? I mean, we haven't changed the system, we haven't changed the way we work in, I mean, many years, probably 60 years, we've been doing the same, which is the patient arrives, the patient registers, the patient waits, the patient waits, the patient waits even some more, then is seen by a healthcare professional for consultation, they discharge, transfer, or we admit him. There are a lot of social, technological, and patient expectations change over the last decades that I don't think we are ready and we are catering for it. The emergency departments fail to keep up with these developments. That's a fact. I mean, I think everybody, the audience, and everybody working in the emergency department, we got this every day. And obviously, from a clinician perspective, where are we now? Obviously, the departments are always busy, under pressure. The waiting times are longer. We haven't got sometimes a good record keeping. There are many complaints and concerns that we have to face. It's very difficult in the emergency departments to establish accurate audit and data collection. If there is these inefficiencies in the medical staff, that leads to poor performance. There are many duplication of processes. There's a lot of time that we have to spend writing clinical records. Sometimes, we fail to meet targets that even our politicians or the guys in senior management put on us. We try to manage everything as a crowd management, no as an individualized patient's care. I mean, it's only a review of the time that we spend with the patients. I mean, F1s and F2s in the UK system are like residents, junior doctors, and you can see that they spend most of the time with the patients, probably because they are less experienced. But it's a lot of time that we, especially if you see this is the time that we have to spend writing history. And you can see that it's a lot of time, 71%. We all know that. I mean, everybody that works in the emergency department know the time that we spent doing very, very valuable tasks that we could do or we can spare, if we have some technological help. And the patients, 80-90% of the time that the patient is in the department, they are simply waiting because they get triage, they wait, they are called, then they wait, to be seen by the doctor, then the doctor orders some tests. I mean, think about it, because the journey, I think, of a patient in the emergency department is well known by everyone. The longer the patients wait, the less time the clinician has with them. So it's an inverse relationship. The longer the patients wait, the more the complaints. It's that direct relationship. I mean, most of the complaints in the emergency departments are because they are waiting, or the patient perceives that they are waiting inappropriately. Frustration at doing nothing for several hours, waiting for something to happen. There is a feeling of inadequate consultation after the long wait. Is that it? There is a feeling that information wasn't conveyed bilaterally. And during post-consultation, there are communication issues that we all know. I mean, you can see in this slide that the downtime is the time that the patient spends in the emergency department. So it's a big percentage. And then compared to the time that the patient is spent interacting with us or receiving care. So what we do is trying to get downtime solutions. Is what can we do in that time that the patient is waiting and it seems to be wasted. So we are creating, and the concept of downtime, of trying to sort the problem out. What we try is we said is embrace technology, trying to get, a patient-centered approach solutions with current NHS concerns and future design. I mean, we have to bust the myth that the patients don't know anything, that they are part of the problem, that our perception that they are most of the time satisfied even with brief interaction and explanations, that they don't have anything to offer to contribute to the care. I mean, we disregard them really. Usually, we also say that the patient are our enemy. They are drunk, disrupted, angry. Um, Obviously, the lack of communication also we blame to how busy we are. We think there are no better ways of doing things, and basically most of the time we think that we need to build walls and to try to separate them from us. As we said before, we are offering more crowd management and not personalized care. So the downtime solution, that's why we started with this project called Smart ER. So we want to use downtime more efficiently. If the patients are waiting, can they help? I mean, they possibly have 80, 90% of the data that we need to make the diagnosis. I mean, probably if they could have more time telling us what's wrong with them, obviously probably they will give us more info, and then we probably will reach diagnosis and will reach a better care for them. We can engage with the patient from the moment that they start waiting. Everybody has a smart device now at the moment, smartphone, tablet, laptops, and everybody comes to the emergency department now with their mobile phones. If not, we can provide kiosks in which the patients can interact. We can even provide with tablets or any laptops or anything that the department can provide. We can give an application that can give some ownership to most patients while waiting. We can improve the experience, and we can improve performance and efficiencies. We can develop applications in other settings where the patients are waiting. So while the patient is waiting, we can do data collection. The future, we'll talk about the data analysis. We reduce the variation in one of the part of the system, so it reduces the whole system variation. The aim is to reduce variation in data collection. I mean, how many times the patient changed the history from one healthcare provider to another. I mean, from triage to be seen by the doctor, the patient sometimes, change the history, and that confuses us. And imagine if the patient is writing his own history in the own device, appears in our screen. That's in our Smart ER is about. Obviously, is consistent with any public health, with any healthcare organization. Obviously, we are trying to develop algorithms, obviously based on the information that we are collecting. The data analysis can be supported, and the data collection is even sometimes direct and live, happening at the same time. So this is what we do now at the moment. The patient attends the emergency department, he registers. If he's suitable for the Smart ER, he starts interacting with the Smart ER, even via console, via tablet, via their own device. The history is taken from the patient because the patient is writing the history in the system, in his tablet or in the kiosk or in their tablet. Obviously, you can see all the travel and all the information that we can download. Obviously, we can start in identifying all the toxic habits. We even can start even interacting the system automatically, can give advice. They can be waiting down and then interacting with the system at the same time. And we can identify allergies. We can even interact with friends and families. We do a summary to confirm accuracy. Obviously, the portal and the system, when we see the patient, is open, and then everything is uploaded, we submit, and we can print it on a scan on a file. So who is suitable for a Smart ER? Usually are patients that can interact with the system. Obviously, they have to be alert and orientated. They are patients or carers have to be able to use applications. Not to use a mobile device that a lot of people obviously do. Obviously, no contraindications to use, because this is not to stop the flow of being triaged and be identified as a critical intervention needed, and obviously depending on the ability of the application. And you will see, obviously, that most of the people that come into the emergency department on a daily basis are suitable for the Smart ER, because approximately we found that 80% of the patients that attend an emergency department daily are suitable for this, because I mean that happens in every emergency department in the world. I mean 80%, really between 75 and 80% are people that come ambulance and are people that come with a minor illness. Even now, after we started developing and putting this system in motion, we are trying to make change in order for this system to be applicable to major illnesses as well. Obviously, it's more inclusive because we can put this Smart ER in many languages. Obviously, the UK is a multi-ethnic country with people speaking lots of languages, and then we can put the system, and and we've been using the system I think it's been translated already to 17 languages. This is how the architecture overview on how the Smart ER works computer-wise. I mean, sorry, this slide is very, very, very thick, but mainly you can see, and as I said, I'll be happy to share this presentation and to have more information, because a waiting patient can produce a lot of information for all these 1, 2, 3, 4, 5, 6, 7. So it can give us information, obviously the history from the patient. It can help us to research. It can help us to advertising, to advice, to education, to even pediatric care for the kids, friends. So the implications of a patient waiting and downloading information to us and to the system are massive, and we are seeing that. And Smart ER obviously communicate. Smart ER has been developed to address the in-reach problem. It allows a patient to enter clinical data regarding their condition, optimize questions of help and determined by the condition of the patient. Obviously, using Smart ER, we can coordinate the in-reach and the outreach care. Post-visit digital care models they are developed at this moment based on conditions determined in the department. We can auto-generate information more efficiently, and allows a secure, personalized patient record to be created by the patient for the patient in the health space. And obviously, the outreach beyond the emergency department is the digital health allows care models to extend beyond the emergency department, because the patient is going to be going home with the application downloaded, and we still can communicate and with the technology at our disposal. I mean, everybody now has a smart device, and we know how we interact now with the digital technology. And even we can send personal health information and outcome of the data through the patient health. Obviously, it will allow, and is allowing, some interaction with other care providers, GPs, nurse practitioners, social workers, et cetera. Obviously, we are seeing that provides an insight in the models, to determine how effective, how efficient, and how satisfied the patients are. And this is again, a total healthcare platform, which we want to do with the Smart ER, in which the patients are the components of the solution, and through the Smart ER, we interact and we can create a lot of data to help the patient and to personalize their care as much as possible. Obviously, we are seeing that Smart ER is providing at the moment key operational and clinical benefits to the department and the patient. A Smart Communicate allows patients' health space to be created and populated with personalized conditional information, and the outreach digital care models can be developed for patients, which obviously put the patients at the center of the care process, allow care to be seamlessly delivered across the care spectrum. The models can be built to include all providers, and models can interoperate with the system, and the model can be measured and optimized to provide optimum combined care on personalized basis. So it's all about trying to get the patient at the center, to follow it up, and to interact with other systems of healthcare. We can do a screening of patients. We can obviously know about the toxic habits or anything that we can identify and we can help with. For example, if they are not doing enough exercise, we can provide information about how can we do exercise promotion. Is all about how to send information to the patient health space. The platform can be used to connect the patient to community-based services like Aspire, or that's in the UK, or social workers or whatever. Obviously, it's an opportunity to educate, inform the risks, and try to change health behaviors. That is one of the problems that concerns us more in the public health system, that we are not being very effective overall to change our habits in our population. Obviously, we can increase consistency, reduce the variation, intra-hospital, inter-hospital, inter-primary, secondary care. We have to have central control. We have a central updating. We have bespoke elements, research and updating. And obviously, this is down to the education medical information system that we can do all this with the smart ER, because we can advise, do all the information and improve how we can interact with the patient overall. In other settings, the waiting patients even can help us, like with all the information that they give in the smart ER, how to create new outpatients and how to refer them to the appropriate specialist, interact with pre-hospital. We can interact with radiology. We can interact with everything. And we are seeing that. We have a proof of concept because everybody, probably the audience is asking, and does this work? Obviously, it's been working for 4 years. And this is the first trial that we did in a minor injury unit. We did a trial for 3 months, and we did 6 weeks refine, which is in our training and setting everything in motion. And we did a 6 weeks testing. We tested this with 70, 80 patients per day, 12 hours a day, and it was put into and the EMIS integration into Symphony. And obviously, we target the patient satisfaction, the clinical satisfaction, and productivity. Sorry that we cannot see the results, but everything, because of problems with the slide. But if you see what we tested, patient satisfaction, clinical satisfaction, and productivity, everything was positive. Patient satisfaction increased. The clinician satisfaction obviously increased, because think about that while the patient is waiting, he's interacting with the system, and you got all the information in your computer when you see the patient. And obviously the productivity increased, because it reduced the time that we have to be writing notes and doing times, especially the healthcare practitioner. That was sorry, see if I can pass. Yeah. Obviously, one thing that we are seeing after we implemented the smart ER is data is power. And this is another way we are now. We have been acquiring 4 years now since the system was put in motion of data. And obviously, there are some questions about how we can comply with the data law protection. But we have all these, what we saw at the beginning, is now we have it, because we have a lot of data. Now is where artificial intelligence will have to help us to try to work out what we're going to do with this data. Sorry about this slide. This is what I wanted to show from before. That is about this is all the results that we are seeing after applying the smart ER. The patient gets more personalized care. They communicate bilaterally with us. Obviously, the waiting times are decreased, and the processes are improved. There is more satisfaction. There are better consultations. There is better post-consultation communication, and is less likely to return. That is one of the quality indicators of the emergency departments, and we can use it in different languages and modalities. For the healthcare practitioners, obviously, we have more accurate history. They are already written. We don't have to write it down. A better communication. We'll have more time with the patients, interacting with them. We have less time with the computers, because the patient is already writing the history to us in their device and appears into our screen. We are more efficient. Obviously, the language difficulties are overcome because the patient is writing in their own language. Even disability difficulties overcome because we can optimize the time with them. In terms of the department, obviously it's a cost. It will reduce the cost. We increase the income. It's better flow. We increase the productivity. Less complaint. There's less negligent claims. It's better data. It's mandatory with all the quality indicators. We have central management of real-time data, happier patients, and from the public health system, obviously, is very advantageous as well because they have better data consistency, they reduce the cost. It's applicable across other areas, even in our primary care and whatever.
Dr. Maya, can you conclude, please?
Yeah. I mean, so obviously what we do is integrate this into what we already do, which is self-registration triage, and the smart ER will apply. And the summary concepts are we have to understand the downtime. Obviously, I think I try to probably make you aware of that. We have to change into a patient-centered process. The process works better with increased activity, and it provides better engineering. Patients are part of the solution. We can improve the in-reach care. The outreach care is a third solution to constraints. We have to bring order versus chaos, and it's the emergence of emergency medicine. As Einstein said, doing the same things again and again and expecting a different result is a definition of madness. The only thing that is constant in the universe is the speed of light. Everything else is relative, even time. So this is what the system is. We hope and happy to answer any questions that you have. And if you want more information, happy to provide this as well. Teşekkür ederim. I finish now. Thank you.
Thank you, Dr. Maya, for this useful presentation. Do you have any question? Okay. Okay. Okay.
So for our next presentation, I will be presenting my colleague, Nasmin Guler, who is the expert in medical hypnosis and emergency medicine in France. She will be talking about the uses of hypnosis in emergency medicine. We have a question here.
Yes. Okay, Türkçe konuşayım mı? Okay, if you want, I can speak in Turkish. It's not a problem for me. Okay. It's better for me.
No, for sure.
Antoine, it is a problem for you? Okay. Test. Beni duyuyor musunuz? Okay, süper. Çok güzel. Şansıma Türkçe sunuyorum. Daha hızlı sunabileceğim ve daha çok bilgi verebileceğim size. Çok mutluyum bu sebepten dolayı. Antoine, tu comprends tout? Yes? Okay. I understand everything. Bildiğiniz gibi acil uzmanıyım. 2005 senesinde mezun oldum. 2012'den beri acilde hipnoz uyguluyorum ve uzun yıllardır tecrübem var ve bu konuda inşallah sizi ikna edebilirim acilde hipnoz uygulamanız için. Bu konuda zaten Başar Hoca ve Mehmet Gül Hoca'yla düşüncelerimiz var. Belki yakın zamanlarda size bir atölye çatısı altında bir eğitim teklif edebiliriz. Bunu hatırlarsınız. Tenten dizisindeki fakir. Deli olduğumu düşünüyor musunuz? Yok. Sizce benim gözlerime bakarak beyninizin kontrolünü alabilir miyim? Alabilir miyim Behçet Hoca? Okay. O zaman bakalım alabiliyor muyuz, alamıyor muyuz? Keşke alabilseydim. Gerçekten hastanedeki yönetimdeki insanların beynini çalardım ama benim gayet işime yarardı. Öyle bir gücüm, kuvvetim olsaydı. Bildiğiniz gibi acilin ortamı çok stres, çok büyük bir anksiyete yaratan bir ortam. Özellikle korku, ağrı, stres, öfke, özellikle öfke patlamaların çok olduğu yerler ve gerçekten bu ortamda çalışmak ve yaşamak çok çok zor. Çünkü bizim de kendi ayna nöronlarımız var ve ayna nöronlarımız olduğundan dolayı bizde de çok kaldıramayacağımız duygular uyandırabiliyor ve sonuç olarak öfke patlamaları çok yoğun olan bir yer. Sizce tabii ki doğru bilinen yanlışlar var ki zaten bu sebeplerden dolayı yıllardan beri acilde zaten hipnoz uygulanmıyor. Yıllardır böyle, çünkü işte psikiyatride yapılabilir, işte anestezide yapılabilir ama acil kesinlikle yeri değil ve ön yargılardan birisi işte bir zaman kaybı. Çok fazla ses var, hastaların direnci çok yüksek. Hele hazırlıksız kesinlikle olmaz diye ön yargılar var. Bakalım bunları bir bir yıkabileceğiz mi? Başlangıç olarak vaktimiz var. Son sunum olduğum için biraz 5 dakika fazla sunum ekledim. Size 2 tane video gösterebilmek için ilk videoyu gösteriyorum. Belki aranızda bazıları görmüş olabilir bu videoları. Tekrar gösteriyorum görmeyenler için. Omuz çıkığı redüksiyonu. Bu hastamız diyaliz hastası. Daha önce omuzu çıktı ve acile ağlayarak geldi ve dedi ki ben ilaç istemiyorum. Lütfen bana ilaçsız müdahale edebilir misin? Ben evime bir an evvel dönmek istiyorum. Haftada 3 sefer acile gidiyorum artık, hastaneye geliyorum ve ben artık hastane görmek istemiyorum. Gördüğünüz gibi röntgene gerek yok, omuz çıkık. Hepinizin bu konuda zaten tecrübesi var, biliyorsunuz. İlaç, serum takmamız gerekiyor, monitoraj, midazolam, süfentanil, değişik ilaçlar kullanmak zorunda kalıyoruz. Hipnoz seansı genelde anestezi gibidir. Endüksiyon vardır, derinleştirme vardır, çalıştığımız an vardır ve ondan sonra hastayı uyarma vardır. Ve bunların hepsini ilaçsız yapıyoruz. Serum takmadık hastamıza, dikkatinizi çekerim. Şu an endüksiyondayız. Yavaş yavaş derinleştirmeye geçeceğim. Özellikle nefes odaklı, nefesinizi takip edin şu an diye hastaya telkinliyorum. Gördüğünüz gibi aşırı gencim. Yıllar önce yaptığım ve hemen eğitimden çıkar çıkmaz yaptığım bir hipnoz tedavisi. Arkadaşlar, videoları çekiyorsanız da sosyal medyaya koymayın. Çünkü gerçekten arkadaşlarıma, bu hastalara söz verdim sosyal medyaya sızmayacağını videoları. Çekebilirsiniz ama kendiniz için. Efendim? Ona ne söylüyorum? Nefesine odaklanmasını gerektiğini söylüyorum. Ondan sonra yavaş yavaş, şimdi bana lazım olan ne? Rahatlaması ve omuzunu hissetmemesi. Yani ilaçların yaptığı şeyleri ben telkinliyorum. Omuzunu artık hissetmiyorsun, rahatlıyorsun, kasların gevşiyor. Direkt telkin veriyorum ve yavaş yavaş zaten hastamız rahatlıyor. 5 dakika sonra redüksiyona başlıyoruz. Hastamızı genelde güvenli bir mekana gönderiyorum ve orada omuzunu bana emanet etmesi gerektiğini, yani disosyasyon teknikleri kullanıyoruz. Burada bana omuzunu emanet etti. Arkadaş çekiyor ama biliyorsunuz normalde bu prosedürler çok bazen hızlı güç kuvvet isteyen prosedürler. Hastamız biliyorsunuz hiç bağırmadı. Bazen 2 kişi tutuyoruz biz acilde gerektiğinde.
Pas forcément exactement ce que vous me disiez, j'arrive pas forcément à suivre ce que vous me dites, mais par contre, je viens de... Ça m'aide à me...
Şimdi prosedürü arkadaş kolu çekiyor, ben hipnoz uyguluyorum ama kendim hipnoz uygulayıp da kendim de çekebiliyorum. Bizim acilde özellikle omuz çıkığı, anterior omuz çıkıklarını biz acilciler tekrar yani redükte edebiliyoruz. Posterior ortopedistler, anterior biz yapıyoruz. 6 dakika arkadaşlar, biliyorsunuz acilde normalde 6 dakikada mümkün değil. O yüzden zaman kaybımı gördünüz. İlk ön yargıyı yıktık. Zaman kazandık. Çünkü normalde bu hastayı ben bizim orada critical care üniteye koyuyorum, monitoraj yapıyorum, ilaç yapıyorum, hemşire bulmam gerekiyor yoğunluğun içerisinde. Yani gerçekten yarım saat 45 dakikada ancak hazırlıyoruz hastamızı. 6 dakikada 1 saat içerisinde acilden ayrıldı. Vaktimiz olduğu için ikinci bir video gösteriyorum. Ondan sonra size ikna etmeye çalışacağım bilimsel olarak. Burada ufak bir çocuğumuz var. Bisikletten düştü. Annesi lokal anestezi yapmadan bacağını sütürasyon yapacağız. Bu benim tabii ki ilk başladığım zamanlarda ve o zamanlar biraz tedirgin hipnoz uyguluyordum ve böyle sesimi kısa kısa konuşuyordum. Çünkü biraz utanıyordum. Çünkü herkes garip garip bakıyordu. İşte bu ne yapıyor, işte deli midir nedir diye. Çok sessiz konuşuyorum. Çocuğa tabii ki bir oyun yapacağız beraber diyerek sedyeye getiriyorum. İstediği, sevdiği bir oyunu yapacağını telkinliyorum. Ve tabii ki vizüel fokalizasyon kullanıyorum. Yani karşındaki bir noktaya bakar mısın? Onların tabii ki tekniği çok derin. Hani onu büyük bir eğitim gerekiyor ama noktaya bakabilir misin diyorum. Çocuk bakıyor tabii. Ondan sonra da istediği oyunu oynaması gerektiğini telkinliyorum. Tabii telkinlerken de aynı anda bacağına tabii ki direkt telkin veriyorum. Bacağı rahatlıyor. İşte bir yavaş yavaş bacağı uyumaya başlıyor. Bir daha artık hiçbir şey hissetmeyeceğini, bacağından hafif bir rüzgar geçtiğini ve hiçbir şey artık hissetmeyeceğini direkt telkin olarak söylüyorum bunu. Genelde çocuklara hipnoz uyguladığımız zaman gözleri genel olarak açık kalıyor. Yani ön yargı biliyorsunuz, gözleri kapalı, ondan sonra kendisini teslim ediyor ama burada çocuk gördüğünüz gibi hareket ediyor ve gözleri açık. Ellerini gördünüz mü? Sizce ne yapıyor? Oyun oynuyor. PlayStation oynuyordur muhtemelen. Git bir oyun oyna diyorum. Bizim biliyorsunuz gençlerimiz artık virtüel dünyada devamlı oyun oynuyorlar. Muhtemelen orada bir oyun oynuyor. Bakın yan tarafta ben çok ses yapıyorum ve çocuk çıkmıyor transtan. Genelde bu çocukları birkaç kişi tutmak zorunda kalıyoruz. Ben bir şeyler hazırlarken çocuk genelde ne yapıyorsun diye mesela soru soruyor, anksiyete içerisinde ağlıyor. Gördüğünüz gibi kendi dünyasında. Yarasını temizliyorum ve sütürasyona başlıyorum. Gördüğünüz gibi hipnozu uyguluyorum ve kendim sütürasyon yapıyorum. Yani tabii ki iki arkadaş olduğumuz zaman ben hipnozu uygulayıp sütürasyonu da başka birisi yapabilir. Genelde şu an artık hasta acilde hemşirelere ve hasta bakıcılara da eğitim veriyoruz ki doktorlara destek olsun diye. Normalde bunu bu şekilde hipnozsuz yapmak imkansız biliyorsunuz. Yani çocuk 7-8 yaşlarında bir çocuk. Sütür bitti. Şimdi artık uyandırıyorum. Ne zaman istersen buraya geri gelebilirsin diye telkin veriyorum. Uyandı çocuk gördüğünüz gibi. Transtan çıkması çok enteresan oldu. Şimdi bakın çocuklarımıza bu şekilde yaklaşım yaptığımız zaman ilerideki posttraumatik travmalardan koruyoruz. Benim oğlum 2 yaşında sütürasyon yapıldı ona alnından. İnanın hala da 23 yaşında ve hala da onu hatırlıyor. Şimdi bu reşit insanlar tam uzun onlara bakmamıza gerek yok ama gerçekten ileriki yaşlarında onlara yapılacak tedavilerden bir nevi koruyor gibi oluyoruz yani bunları uygulayarak. Çünkü travmatik hafızayı şey yapmıyoruz, yerleştirmiyoruz. Gördüğünüz gibi all terrain hipnozis dedim. Yani her yerde 4 çeker araba gibi her yerde bunu uygulayabilirsiniz. Yani acilde, telefonda, ambulansta her yerde uygulayabilirsiniz. Tabii ki hani benim gelmek istediğim genel mesaj şu. Yani gerçekten hipnozu elinize aldığınız zaman, kullandığınız zaman iletişim olarak 7/24 her zaman kullanabileceksiniz ve size gerçekten insani ilişkilerinizde çok büyük bir rahatlık verecek. Yani özellikle hastalarla olan ilişkinizde her zaman kullanabileceksiniz. Yani öfkeyi nasıl yönetebilirim, hastanın korkusunu nasıl yönetebilirim? Uzman doktorlarla biliyorsunuz sürekli ping pong oynuyoruz. Yani özellikle mesela solunum nefesi çekiyorsa hasta kardiyologla pneumologla arasında oynuyoruz. İşte karın problemi olduğu zaman hepatogastro ile işte cerrahla arasında böyle bir ping pong oynuyoruz. Yok onun hastası, bunun hastası derken işte bu uzmanlarla bile ilişkilerimizi daha iyi yönetebiliyoruz. Self hipnoziz de çok önemli. Benim için gerçekten hipnozun en büyük katkıları iletişim ve self hipnozuz. Mesela ben gerçekten bu pandemide biliyorsunuz Fransa'nın kuzeydoğusunda çok büyük bir patlama yaşadık. Çok stresli bir dönem yaşadık ve bana gerçekten çok yardımcı oldu. Her gün self hipnozuz yaptım kendi duygularımı yönetebilmek için. Arkadaşlar gerçekten hastaların duygularını yönetmek istiyorsanız ilk önce kendi duygularımızı yönetmemizi öğrenmemiz lazım. Ben kendi duygularımı yönetemiyorsam hastanınkini yönetemem. İşte hipnoz aslında buna yardımcı oluyor. Ve tabii ki videolardaki gördüğünüz gibi formal hipnozu, o da gerektiği zaman eğer hasta gerçekten kendi duygularını yönetiyorsa yani hipnoz uygulamaya gerek yok. Yani sanmayın ki ben her hastaya hipnoz uyguluyorum. Gerektiğinde uyguluyorum o şekilde. Tabii ki sağlıklı olarak kendinizi daha iyi hissetmeniz için. Size gerçekten Inside Out dizisini, filmini bakmanızı tavsiye ederim. Çok duyguları açıklayan çok güzel bir film. Yani genelde bizim korkulu rüyalarımız kim? Mr. Anger and Mr. Fear. Acilde bu ikisi başımıza gelince zaten bunlarla uğraşmak çok zor. Ama artık ben bunlardan korkmuyorum. Bunları çok güzel yönetebiliyorum. Özellikle öfkeli hastalar hiç problem değil benim için gerçekten. Benim aslında genel vermek istediğim insani ilişkilerinde gerçekten bunu bir İsviçre bıçağı gibi düşünebilirsiniz hipnozu. Özellikle tabii ki normal ilaçların yerini tutmaz ama insani ilişkilerde yönetmekte bana göre bu İsviçre bıçağı gibi bir şey. Acilde olmazsa olmazlar, kesinlikle her acilcinin cebinde bulunması gereken, zor anları yönetebilmek için gereken bir uti, bir tools diyeyim, Türkçesini şimdi aklıma getiremedim. Size birkaç araştırma gösteriyorum. Bakın bu araştırmada Elvi Halong 2000 senesinde çıkan bir araştırma. Endovasküler tedavilerde özellikle burada renal damarı kateterizasyon yapıyorlar. Yani arteritik hastalarda. 3 tane gruba ayrıldı. Kontrol grup en üstte. Ortada empati ve en altta hipnoz. Burada anxiety ve ağrıyı nasıl yönetebilir biliyorsunuz, scale'ler var şu tarafta ve gördüğünüz gibi hipnoz grupta daha iyi yönetim var. Çünkü hastanın stresini ve ağrısını daha iyi yönetirseniz eğer daha uyumlu oluyor ve bakın daha erken bitiriyoruz tedavileri. Empati iyi çünkü empatiyle bir grup yapması çok iyi oldu. Çünkü mesela ben acilde başladığımda hipnoz uygulamaya, ya Nazmiye işte sen hastalarla jantisin o yüzden etkili oluyorsun yani diye bana böyle bir ön yargı var. Ama bakın gördüğünüz gibi empati tabii ki kontrol gruptan normal travmatik iletişim diyorum ben ona. O tarz iletişimden daha iyi. Mesela ben laboratuvara gittiğim zaman hemşire güler yüzlüyse gerçekten daha iyi. Surat asıyorsa bende stres yaratıyor yani sonuç olarak. Gördüğünüz gibi ve bu gruplarda ilaçlar kullanıldı. Mesela burada midazolam ve süfentanil kullandı ve en üst grupta, kontrol grupta hem daha ilaç kullanıldı, daha çok ilaç kullanıldı hem de bakın ağrı yönetimi çok kötü. Scale'ler çok yüksekti. Hipnozda az ilaç kullanıldı. Ağrı ve stres yönetimi en düşük seviyede. Şimdi bu yeni bir meta-analiz çıktı 2021'de. Bunu muhtemelen siz isterseniz okuyabilirsiniz. Bakın burada son 20 yıl araştırmalarını bir araya getirdiler ve sonuç olarak bakın hipnoz ağrının %73'üne kadar düşürebiliyor. Yani gerçekten acaba lüksümüz var mı hipnoz eğitimi almamak için? Gerçekten, çünkü hem kendinizi koruyacaksınız, hem hastayı daha iyi yönetebileceksiniz, hem kendinizi daha iyi hissedeceksiniz. Şimdi burada da başka bir araştırma görsel olarak çok önemli olduğu için size göstermek istiyorum. Üst tarafta hastanın bilinci yerindeyken elini lazerle ağrı veriyorlar. Yani elini acıtıyorlar. Bak gördüğünüz gibi ağrı bölgeleri uyandırılıyor. Altta hipnoz uygulanıyor ve ağrı bölgelerindeki aktivasyon sönüyor. Yani hipnozla gerçekten görsel olarak bunu görebilirsin. Beyinde gerçekten büyük bir etkisi var. Yani bu şey değil, yani hayali bir etki değil. Gerçekten beyin görüntülemede bu bir MR veya PET scanner, ikisi kullanılıyor imaging olarak. Görebilirsiniz ki gerçekten hastanın ağrısını çok iyi yönetebiliyoruz ve bunun gerçekten reel bir etkisi var. Burada bir anestezist ameliyattan sonra hastalara nötr bir fluid enjekte ettiği halde bakın yanan bir fluid enjekte ediyorum diye hastayı telkinliyor. Gördüğünüz gibi hepimizin ağrı hafızası olduğu için ağrı bölgeleri uyanıyor. İkinci etapta hastaya ben sana nötr bir ilaç enjekte edeceğim ve nötr bir ilaç enjekte ediyor. Bakın telkinlerin bile normal günlük hayatta ne kadar önemi var. Çünkü bizim gerçekten ağrı hafızamız var ve kullandığımız kelimelere çok dikkat etmemiz gerekiyor. Bunu zaten tomografide çok yoğun yaşıyoruz. Hatırlarsanız hastayı tomografiye getirdiğimiz zaman aman dikkat yanacak, iod enjekte ediyoruz diyoruz. Ben mesela bizim röntgen bölümündeki arkadaşlara lütfen diyorum ne olur artık dikkat yanacak, iod enjekte ediyorum demeyin lütfen diyorum. Diyorum ki gerçekten şu an sakin olun. İşte size bir ilaç enjekte edeceğiz. Bir şeyler hissedeceksiniz. Bir sıcaklık. Bakın yanmak başka, sıcaklık hissedeceksin ve gerçekten sizin için çok hoş olacak diye provokatif bir şekilde telkinliyoruz ve inanın hastanın o anki yaşadığı daha pozitif oluyor. Aynen böyle biliyorsunuz beynimiz negasyonları duymuyor, keywordleri duyuyor. O yüzden hastanıza yaklaştığınız zaman stres yapma yerine sakin olun, rahatlayın. Yani pozitif terimler kullanacağınız bütün keywordler pozitif olsun. Yani canın yanmayacak yerine ne söyleyebiliriz arkadaşlar? Mesela bir çocuğa tedavi uyguladığınız zaman işte stres yapma, canın yanmayacak. Sakin ol, seninle iyi ilgileneceğiz, göreceksin her şey iyi geçecek gibi. İşte kendi kreativitenize bırakıyorum. Gerçekten pozitif kelimeleri kullan. Burada maksat pozitif olmak değil, yani hayata pozitif bakmak değil. İletişiminizi pozitif kelimelere, yani negatif kelimeleri pozitif kelimeye çevirmek. Yani önerim şu, tabii ki hastaya bütün prosedürleri A'dan Z'ye anlatmak zorundayız. Yani gerçekten ağrıyı anons etmeyin, prosedürü anons edin ama ağrıyı anons etmeyin. İşte sonuna geldik, sunumun vaktim var biraz herhalde. Son olarak bakın araştırmalarda EEG'de kesinlikle herhangi bir karakteristik bir tracing yok. Sadece sakin bir uyanık hal olduğunu görebiliyoruz. Ve burada bu da çok yeni bir sistematik review 2017'den 2017'de publikasyona geçti. Bakın şu an artık bütün araştırmalar aynı fikirde. Yani ben hipnoza girdiğim zaman 3 tane network uyandırıyorum. Salience Network, Executive Network ve Default Network. Yani ben bu üçünü birden aktive edebiliyorum. Normalinde ben şu an sizinle konuşurken üçünü birden aktive etmem imkansız. Ama trans halinde bu üçünü birden aktive edebiliyorum. Yani bu ne demektir ki ben kendi içimdeki gerçekten daha farklı davranışları ve daha farklı kompetanslara ulaşabiliyorum hipnoz halinde. Biliyorsunuz ben çocuğa normal halinde şu bacağını uyut demiş olsam veya bir hastaya şu kolunu rahatlat demiş olsam bu kız deli diyecek bana. Ama ben hipnoz halinde direkt telkin verdiğim zaman uyguluyor. Tabii ki hipnozu plasebo olmakla suçlandı ama plasebo değil. Hipnozun içinde plasebo var ama sadece plasebo yok. Tabii bunları anlatmak uzun sürer, vaktimiz yok. Yani sonuç olarak hipnozu her alanda, ağrı ve stresin olduğu her alanda prosedür olsun olmasın. Mesela bir migren için, bir karın ağrısı için bile kullanabilirsiniz. Ben ayrıyeten part-time terapi uyguluyorum. İnanın çok şeyler mesela posttraumatik tabii bunlar terapi, bunlar daha uzun işler de. Ama acilde kriz yönetiyorsunuz. Yani terapi yapmıyorsunuz. Kriz yönetiminde gerçekten medikal hipnozu her alanda kullanabilirsiniz. Özellikle mesela anksiyete krizine girmiş insanlarda çok etkili. İlaç vereceğinize ben 2-3 dakikada gerçekten onları hemen sakinletebiliyorum. Sonuç olarak for every stress and pain okay. Tabii ki ön yargını hastamın direnci yüksek ama bu doğru bilinen bir yanlış. Hastam gerçekten çok büyük bir stres içinde olduğu için siz onun kurtarıcısınız. Ve genelde siz ona ne bir hasta size derse ki eğer lütfen doktor beni kurtarın bu ağrıdan beni kurtarın dediği an zaten sizin etkiniz altındadır ve hipnozu uygulamaya hazır, hipnozu kabul etmeye hazırdır. İnanın ben kronik hastalarla ilgileniyorum. En kolay uygulanan yer acildir. Acilde o kadar kolay ki ve o kadar hızlı hipnoz yapabilirsiniz ki çok basit ve çok rapid. Çok kolay. Çok yani hızlı teknikler var, çok kolay. Tabii ki ilişkilerinizi düzeltiyor ve kendi ruh sağlığınıza da iyi geliyor. Yani sonuç olarak time saving and less medication. Yani bu gerçekten benim atasözüm oldu hipnozda. Gerçekten zaman kazandırıyor ve ilaç da kazandırıyor. Herhalde vaktimiz bitti ama isterseniz prehospital olarak bir video gösterebilirim. Bakmak ister misiniz? El kaldırın. Okey. Tamam. O zaman bir call center'dan da bir ses kaydı dinleyeceğim stres yönetimi için. Vaktiniz var madem. Buyurun. STEMI hastasını ben şu an anjiyoya getiriyorum.
Donc là, je vous montre simplement, on va commencer la séance, tu peux t'exprimer, simplement de suivre votre respiration, d'accord? En remarquant l'air qui entre dans votre narine droite profondément, de la même manière peut-être, ou d'une manière différente, je ne sais pas. Vous allez remarquer qu'il y a plein de bruit autour de vous, à travers vos oreilles.
Bakın ses var, monitör çalışıyor, alarmlar var, hiç problem değil. Ne kadar çok ses, o kadar hipnoza sokabiliyorsunuz hastanızı.
Des mouvements de va-et-vient dans tous les sens. Un et deux.
Monitörajı gördünüz değil mi? STEMI'yi görebildiniz yani. STEMI var resmen hastada. Tabii ki aspirin, tabii ki bütün ilaçları, heparin hepsi yapıldı. Hemen. Şu an bana gerçekten bakın eliyle soruyorum hangi bölge vücudundaki hangi bölge acı çekiyor şu an bana kalbini gösteriyor. Şimdi şu an katalepsi teknikleri kullanıyorum. Birazdan bana neresi ağrıyor diye sorduğumda bakın bana kalbini gösteriyor. Direkt iletişime girebilirsiniz yani hipnozda hastayla. Çok konfüzyon teknikleri kullanıyoruz. Ve şu an ben ona hani vücudunun başka bir yere işte kalbine yardımcı olacağını söylüyorum. Bacağını gösteriyor. Yani burada rasyonelite aramayın. Hipnozda rasyonelite yoktur. Yani zaten konfüzyon teknikleri kullanıyoruz. Şu an şimdi bir çapa yapıyorum. Çünkü ben anjiyoda olmayacağım onunla. Yani bir renk çapası yapıyorum ve telkinliyorum. Kateterizasyon room'da olduğun zaman bu rengi hatırlayarak tekrar aynı şekilde self hipnozis yapabileceksin diye. Bakın ağrısı düştü. Altının üstünde morfin uyguluyoruz. Morfin uygulamama gerek yok. Özellikle kardiyologlar mümkün mertebe yapmayın diyorlar. Çünkü gerçekten hasta o zaman daha çok midesi bulanıyor. Daha az uyum sağlıyor anjiyoda. Ben bu hastaya özellikle hipnozdan çıkmak zorunda kalmadığını ve tedavinin sonuna kadar hipnoz altında istediği gibi girip çıkıp kalabileceğini telkinliyorum. Çünkü ona şu an lazım ama sonra da lazım. Ağrısı düşüyor, 7'den 4'e düşüyor. O yüzden sadece parasetamol koydum. Anjiyodan sonra hastaya soru soruyorum nasıl geçti sizin için diye. İnancı, tabii kısaca şey yapıyorum, inancı olmadığını ve herkese tavsiye ettiğini, ağrısını ve stresini kateterizasyon odasında çok daha iyi yönetebildiğini söyledi, paylaştı bizimle. Yani bakın insanın hayati teklizi en dorukta olduğu halde biz değil mi? Yani sonuçta bir kalp krizi orada bile stresini çok gayet normal bir şekilde yönetebildi ve ben o hipnoz uygulayabildim. Çünkü ön yargı ne? İşte bu durumda hastanın hiçbir yeteneği yok, yapamaz. Gördüğünüz ses kısa sürede ses olduğu halde hastaların direnci düşük. Bütün ön yargıları herhalde kırabildik. Son olarak bu ses kaydını dinle diyorum. Bir tane anne yani görsel olarak hastanızı görmeseniz bile telefonda hipnoz uygulayabilirsiniz. Daha da etkili olabiliyorsunuz. Ses iyi gelmiyor herhalde. Bebeği kusuyor. Yani burada sadece ses tonunu takip edin. Anlamasanız bile ses tonundan hani stres yönetimini anlayacaksınız.
Madame, elle est consciente là actuellement?
Elle ferme les yeux, elle ouvre les yeux.
Vous la trouvez fatiguée, c'est ça?
Oui, oui.
D'accord. Madame, je vais vous envoyer une ambulance et elle sera surveillée en pédiatrie. D'accord?
Oui, merci.
Voilà. Prenez-la contre vous, madame, allez.
Oui.
Vous l'avez contre vous, là?
Oui.
Voilà. Vous allez suivre sa respiration, tranquillement. D'accord?
Oui.
Allez, vous sentez sa respiration?
Oui.
Voilà. Elle respire comme il faut?
Oui.
Voilà, donc maintenant vous allez vous synchroniser avec elle, respirer avec elle. Vous allez voir, si vous vous calmez, elle va se calmer. D'accord? Voilà. Donc vous allez garder votre calme pour lui transmettre votre calme.
Oui.
Voilà. Ça va mieux?
Oui.
Madame, les secours sont partis, hein, ils vont arriver très vite, d'accord?
D'accord.
Soyez rassurés. Ok?
Oui.
Vous l'avez toujours contre vous?
Oui.
Voilà, ressentez bien sa respiration. Prenez une grande inspiration, madame. Voilà, c'est bien, très très bien. Et vous allez ressentir votre bébé contre votre peau.
Oui.
Voilà. Vous voyez bien, regardez.
Tabii bir
elle est-
acil
elle est
uzmanı
plus
olarak
sereine,
benim
elle pleure,
görevim,
c'est
çünkü
bien.
biz triyaj yapıyoruz
Voilà, madame,
112
c'est très, très
santralde.
bien.
Çocuğun iyi olduğunu
Continuez de
tabii
bien la garder contre vous, de
anlamak.
bien la ressentir contre
Çocuk
vous.
iyi, rahatlıyoruz.
Voilà. Ça va mieux?
Anneyi sakinleştiriyoruz gitgide.
Voilà, très bien.
Gördüğünüz
madame.
gibi
C'est très bien
bakın
ce que vous faites.
dediğim
Prenez-la
telkinleri
contre
direkt
vous,
dinliyor. Ne kadar
ressentez
derin
bien le
nefes
contact de
alıyor.
vos bras sur elle.
Derin nefes al diyorum, dibine kadar nefes alıyor.
D'accord? Très bien.
Burada
Voilà. Et
sadece
vous prenez
solunum
une inspiration
telkinleri
profonde,
veriyorum.
de plus en plus profonde. Voilà, c'est très bien. Très très bien.
Ses
Et
tonunu
vous allez
farkını
ressentir l'air
hissedebiliyor
qui
musunuz?
entre dans votre narine droite, profondément. Voilà, c'est très bien. Et l'air qui entre dans votre narine gauche, de la même manière peut-être, ou d'une manière différente. Voilà, c'est bien. Ça va mieux, madame?
Oui.
Voilà, c'est très très bien. Donc vous continuez de la garder contre vous et vous suivez votre respiration et la sienne, tranquillement. Et les secours arrivent très très vite. D'accord?
Ils arrivent, d'accord.
Ils sont déjà sur la route, madame. Soyez rassurée, votre gamine, elle va bien. Regardez, elle est calme. Et vous lui avez transmis votre calme, c'est très bien.
Merci.
Voilà, madame, c'est très très bien ce que vous
Bir
faites.
de bir
Continuez
merci
comme ça.
alıyoruz sonunda gördüğünüz
Allez,
gibi.
madame, au revoir.
Oui, au revoir.
Sonuna geldik herhalde. Teşekkür ederim. Soruları olan var mı? Zeynep hocam? Behçet hocam her zaman sorusu var. Buyurun. Sor.
Teşekkür ediyorum. Gerçekten çok istifade ettim. Daha önce de benzer bir şey bir yerde görmüştüm. Şöyle, şimdi Nazmine hocam bahsettiği şey gerçekten insanı bir alemden başka bir aleme götürmektir. Mesela bizim bildiğimiz işte buna işte görünür veya şehadet alemi, yani cismen yaşadığımız şey. Bunun dışında işte mana alemi var, hayal alemi var. Hayalde yaşıyoruz, uyku alemi var.
evet, tabii.
Uykuya giriyoruz. Halbuki her şeyimiz fizyolojik olarak çalışıyor. Ama biz başka şeyleri duymuyoruz. Misal alemi var. Böyle onlarca bu şekilde alem var. Ve insan bunu buradan buraya götürebiliyor. Şöyle bir şey söyleyeyim. Ya bir sözden su olur mu? Yani bir kelime söyleyeceğim, bu su olur mu? Oluyor. Mesela nasıl? Mesela örnek olarak hani Zeynep hocam bana kırılmayacağını bildiğim için onu ben şimdi kötü bir kelime söylesem hemen su olup gözyaşı akıtır, su olur. Evet. Kelimeden öfke oluyor mu? Evet, olabiliyor. Özlem hocama bir şey söylesem desem ki mesela eşiniz artık sizi sevmiyormuş filan. Hemen değil mi bir öfke
Aman.
olur. Öyle şey yani nazım geçtiği için onlara söylüyorum. İstersen şey söyleyeyim. Aynen bunun gibi kelime painkiller olabilir. Yani
Kesinlikle.
İşte buna işte isim konulmuş, hipnoz denilmiş. Yani kelimeden ağrı kesici ilaç olur. Kelimeden ağrı da olur. Kelime
Telkinler
söylerseniz,
işte kullandığımız
kalbime dokunduruyor diyorsunuz. Tam kalbime indirdin. Hakeza kelimeden mutluluk olur. Kelimeden su da olur, gözyaşı da olur. Teşekkür ediyorum. İstifade ettiğim için paylaşmak istedim.
Evet Behçet hocam, katılıyorum size. Normal hayatımızda farkına varmadan zaten hipnoz uyguluyoruz. Ama tekniğini öğrenirseniz daha da etkili olursunuz. Gerçekten hani tavsiye ederim. Çok teşekkür ederim. Ben Başar Hoca'ya ayrıyeten ve takımına ayrıyeten teşekkür ediyorum bu davet için. Ve ayrıyeten Emre'ye de, Emre Tetik'e de çok ayrı teşekkür ediyorum. 7/24 gerçekten bütün sorularımıza cevap verdi. Her konuda yardımcı oldu bize. Gerçekten hepinize çok teşekkür ederim.
Affedersiniz, ben bir soru sorabilir miyim? Beni göremediniz arkada da. İsmim Doktor Alten Oskay. Bir kere hipnozun acilde kullanabileceğine inananlardanım. Elinize sağlık, tebrik ederim.
Teşekkür ederim.
Bunun dışında galiba yurt dışında kullandınız. Türkiye'de hiç denediniz mi?
Tam anlamadım. Mikroyu yaparız. Yurt dışındası gerisini duymadım.
Türkiye'de kullandınız mı? Hipnozlu acil serviste.
Şimdi ben yurt dışında çalıştığım için, yani Türkiye'de çalışmadığım için uygulamadım.
Peki aydınlatılmış onam gibi bir şeye ihtiyacınız var mı?
Hasta tarafından mı diyorsun?
Evet.
Şimdi bizim Fransa'da artık hipnoz herhangi bir onay istemiyor. Yani ben bazen anons ediyorum. Çünkü hipnoz, morfin gibi hipnoz yapacağım dediğiniz zaman morfin gibi etkisi oluyor. Hasta zaten hemen sizi dinlemeye başlıyor, etkileniyor. Mesela kalp hastası için vaktim oldu haber vermeye ama çocuk için yani anlamaz diye haber vermiyorum. Ya duruma göre ama yani resmi, legal olarak herhangi bir izne ihtiyacım yok. Onu o şekilde yani zararsız bir yöntem diye Fransa'da zaten kabul etti Fransız Tıp Akademisi.
Peki acil servisin ortasında uyguladığınız zaman özel bir odaya
Thank you very much, Hannah, for this very nice invitation. It's a privilege for me to be the first speaker of this huge congress, and I think that what you did in this session is to address the importance of invasive technology as a new opportunity to increase the powerful of emergency medicine worldwide. I really am happy to address this topic, and this topic is coming as the need, and we will see during my presentation, to work together. Not only emergency physicians, but radiologists, interventional cardiologists, to produce more evidence and publications, as we did into the great network, worldwide academic research organization that is with Watson worldwide trying to increase the powerful of publication in our group. And I really appreciate that you put in the backs many journals, because this is the future of emergency medicine, to produce evidence. So let's go now and see, after my disclosure, what are really the need for technology support after clinical evaluation. Before starting my talk, let me tell you that no technology can support a bad emergency physician, because the best technology emergency physician has is his holistic opportunity to visit the patients and make clinical decisions. By the way, in the last 25 years, we saw an important increase in quality of laboratory testing, especially biomarkers in acute disease and point-of-care biomarkers, but also technology of imaging. So laboratory testing and imaging are going to be the big revolutions in our job to increase the quality of our medical effort and, most importantly, increase patients' outcome. When you talk about imaging, for sure you know that ultrasound have totally changed our ability. Every emergency physician now are able to perform ultrasound, and I'm very proud that we were the people that teach cardiology on how to use chest ultrasound to detect many diseases they were not able to do. But nevertheless, besides the ultrasound that are growing impact, there are other technologies such as point of care, looking at the computer-assisted imaging, but last but not least, the angiography. Angiography is really important, and I think it's something that can really improve our knowledge and also quality of health delivery system. But of course, the issue here that angiography need a cath lab or let's say radiology interventional box that should be as much as possible close to the emergency room. So this is the first example. 250 years ago in my regional city, Naples, these researchers put some substance into the vessels of humans. And these skeletons are still there in Naples, one man and one woman. And you see, he put this injection, but unfortunately, patients died. But luckily now, we have many different radio contrast possibilities that are able, thanks to invasive medical imaging technology, to use this iodinated contrast material to visualize the lumen of blood vessels. And this is very important because thanks to the angiography, now we can have a very clear opportunity to see the brain, the neck, the aorta, the chest, the gastrointestinal tract, and so on. But what is important, not to abuse the technology, but to make the right decision. First of all, now blood vessels should be evaluated also with non-invasive technologies such as ultrasound, echo Doppler, TC scan, and magnetic resonance imaging. Nevertheless, although these new non-invasive technologies are going to be every day much more precise, we still need angiography, catheter-based, in the cases you need immediately decision-making to transfer the patient to surgeon, or last but not least, to have access to intervention radiology procedures that can impact the length of stay of our patients in the emergency room, and also to reduce the length of stay in the hospital and the costs related. So this is the way you have to think about how angiography can really increase our emergency department job every day. So I have one question for all of you. How many of you today have an angiography service available 24 hours, 7 days in your emergency department? Please raise your hand. Not so bad, 15%. Okay, let's see if the other 85% could be convinced at the end of my talk to try to insist to have an angiography box in their emergency department. So, and I think this is coming to the fact there are so many acute diseases that are allocated here, such as acute myocardial infarction, multiple pulmonary embolism, trauma, that can benefit having an angiography area into the emergency department. First of all, let me address my special topic, acute coronary syndrome. We know that time is myocardium, so you really want to start as soon as possible in the emergency department to reopening the vessels in the case of MI. These recently published 2019 guidelines on how and when to perform angiography in acute coronary syndrome is very clear that in the case of elevated ST myocardial infarction that is within 12 hours, you should do evidence 1A, in all these cases, a PTCA. And then that is a delay opportunity, still evidence 1A, if you have no cath lab available, that you can do fibrinolysis. So in any way, you are going to perform in many patients as soon as possible angiography, coronary angiography, and then opening the vessels. This is a cartoon that I would like to take in mind, but I'm sure everyone in the audience is aware. In the case that you are able to make EKG in 10 minutes, and you are going to refer an hospital where the cath lab is not available, you have two choices. If you are the STEMI, in between 120 minutes, in that case, you can refer for 90 minutes, transfer the patients. Alternatively, if you have 2 hours that the STEMI is started, you can start fibrinolysis there, and then you can reperform in 10 minutes, transferring the patients. But if you have the cath lab, angiography, and the coronary PTCA available, you should do this in less than 60 minutes. I think it's very important to save as much as possible lives in acute coronary syndrome in our patients, what about if I have a patient with not ST myocardial infarction elevation? In this case, there is the opportunity, if the patient is very high risk, also to go for invasive procedures if the patient is hemodynamic instability, if there is life-threatening arrhythmias, and also acute heart failure. So still in these patients, you can do PTCA within 2 hours. So something that you could do there, because you are going to save and increase the number of lives in the emergency department. So let's move now. Another important frequent reason for patients coming, pulmonary embolism. In this consensus statement for multidisciplinary physicians, it's very clear that in the case there is a big embolus that is very close, massive embolus, very close to the original pulmonary artery, you should do catheter thrombolysis and removal of the thrombus. So it is very important also to consider in patients presented with the syncope, massive TC scan, pulmonary embolism, to do angiography and remove the clot. Now, what about the need also to look at the aorta during patients coming in? I'm sure experience with patients coming with chest pain, you are looking for acute myocardial infarction, the patient can have aortic dissection. So aortic dissection is really a situation where the emergency physician can have the need to make an aortoangiography. What the guidelines say that the most risk is the ascendant aneurysm and the dissection, where the patient should be immediately treated with the beta blockers. All these patients should have beta blockers and then transfer immediately to cardiosurgeon in order to make a decision. So aortic dissection is another really important situation when you need angiography to perform as soon as possible. Now, I'm sure also in your daily practice experience, you are managing with the patients coming in with acutely cool, painful leg, and in this case, you really are going to clinical put a suspicion of acute limb ischemia. In this case, you can perform a Doppler that is mandatory, and in the case of Doppler, you can have 3 possibilities. Assuming that you have no artery in the, let's say, pink area, sound, no vein sound, don't waste time. Ask the surgeon to make amputation on the leg. On the other side, in the green area of this cartoon, if you have a presence of audible artery and veins, you are going to do angiography because you want opening the vessels that bring blood to the limb. So I think it's very important also in the acute limb ischemia after the clinical judgment and also non-invasive assessment to go for an angiography. Now, another important issue where the angiography is going to be increased, the role is a stroke, both ischemic and hemorrhagic stroke. In ischemic stroke, in the case of these 6 possibilities, pre-stroke MRS score between 0 to 1, causative occlusion of the internal carotid artery of MCA segment 1, age greater than 18 years, NAIHSS score greater than 6, aspect greater than 6, treatment of removal. The occlusion of the artery should be done after angiography, but in the case of the symptoms are greater than 6 hours, and you cannot do thrombolysis. But what is important, this leads to the need, like the recommendation, guidelines 2018 are going to put out the importance of a multidisciplinary team that is my auspicious in this conference. Opening the ceremony, I think is a very good opportunity for me to tell that we have to work all together in order to improve our skills and patients' treatment. And also it is important that angiography should be there in the case of ischemic stroke. And also it is important that you want to monitoring. So our job is not only to start appropriate treatment, but to monitoring patients' outcome and publications on the results. What about hemorrhagic stroke? There is no doubt there are a lot of situations where you can use clipping or culling of the hemorrhagic site after brain angiography, and then you can save the patients, especially if he has hemorrhage due to cerebral aneurysm. So it is very evident that so far we addressed the important possibility to check in the case of acute coronary syndrome, acute aortic disease, and acute stroke, the possibility to use angiography. Now, what about trauma? There is no doubt that looking at a lot of bleeding that are going to be not able to stop because of what you're doing with the medical treatment, you should need an angiography. In this case, what is important as an example of the very severe trauma is liver trauma. In the liver trauma, you should consider two classifications. AAST, liver trauma classification, but also when you put together, let's say, the injury type, the grade, and injury description, you should also put one important, very, very important evaluation, the hemodynamic instability. So I would like to emphasize this important clinical judgment of hemodynamic instability, because if hemodynamic instability is present in the case of a liver trauma, you can go a very severe lesion to WHS, ESIV, and go to operating room immediately after an angiography. So there is no doubt that also in the case of liver trauma, you can have a lot of possibility. And I think that this is going to be of a great importance also in other trauma. Now, you know, our neurosurgeons are very good and with the intervention radiology to make spinal arteriography. And in the case of spinal trauma, they are able also to make embolization of very small vessels of our spinal doors and resolve the issue. So now let's move to the last but very important topic, that is acute gastrointestinal bleeding. I'm sure you are fighting every day with a lot of geriatric people coming in, taking anticoagulants, even decumarol, or new anticoagulants that have a lot of bleeding, especially if they take decumarol because they are able to control INR. So there is a very important, again, the need for an emergency physician to assess the hemodynamic instability and then immediately to perform an upper endoscopy. If the endoscopy is negative, you can go to check the colonoscopy, but if it is not possible to be prepared because you need colonoscopy, you need preparation, then you can go immediately for angiography. That is really something that emphasizes the need to have angiography area where you can do a lot of important setting decision making. Now, what about embolization? I am sure this has been, during the last 10 years, the revolution in stopping bleeding. And you can see from these data coming from registry, you can see that in trauma, the overall success of embolization is around 100%. Amazing. Amazing. You can solve the issue in many trauma, and also in the case of gastrointestinal bleeding, both from upper or lower sides of the enterical system, you can have embolization that are going to save lives. So it's not only a problem of hemorrhagic situation, but also of ischemic. Acute mesenteric ischemia is another important situation where, again, starting with the clinical suspicion, you are going to look about the possibility to have acute mesenteric ischemia and then to do CT scan and angiography. And also, in this case, you can have arterial thrombus that you can find, and then you can open the vessel. So I think it's very, very important to make important decision where to move or not from non-invasive clinical assessment to angiography. It seems to me there is a lot of room to improve and to need of angiography in acute setting. Let's talk about the contraindications. The last 2 minutes of my talk, I will address this important situation. Let me tell you that there are not really many contraindications in the case of need to perform angiography. You just need to make sure the blood pressure is quite controlled. You don't want to make sure that there is a renal insufficiency, so that the iodide contrast material is not going to deteriorate the damage, the function of the kidney. But thanks to the new quality of a new product, this issue is going to be very low. So in the future, my friends, we are going to have a lot of people, especially because life expectancy is worldwide increasing. And for the reason of that, we should, and also geriatric people, they have a lot of bleeding. We should really think about to increase our angiography performance into the emergency room. And these are my conclusions. After an initial clinical non-invasive technology evaluation, I put this in red because it's the starting point. Please don't go immediately to angiography unless you have not made clinical judgment. In any case, it represents angiography a cornerstone in various clinical situations in the emergency department. It is also important because you are going to reduce the time of saving life and in hospital length of stay, so you can also save a cost. And in the future, I think it's very important that we are going to increase working together in the skills of angiography. But what do we need? We need research, data publishing, because like this consensus statement on academic emergency medicine pointed out a couple of years ago, in order to optimizing emergency department, the diagnostic imaging has the potential to improve the quality, safety, and outcome in the emergency department. Because also don't forget the radiation are potentially dangerous for your patients. You really want to vote for the right patient, and we need the data. So my final auspicio will be to produce more data in this setting. And thank you again for giving my talk. So just the last 20 seconds, how many of you now are happy to have an angiography service next day in your emergency department? Yeah, I think it's increasing. I was expecting more, but that's okay. It's coming from 15% to 30%. Not bad, actually, without our auspicious. So in any way, if you want really to contribute to our research, please come to Edinburgh or this biomarker, but last but not least, in San Diego, where we are working in implementing the geriatric emergency medicine, where I think angiography should be a big value. Thank you very much for your attention.
Thank you, Dr. De Soma. That was fantastic. At this time, are there any questions? I have a question for you.
Good.
That was a fantastic review of all the ways that we can use angiography in the emergency department in acute setting. It's not only diagnostic, but it's therapeutic as well. Do you see angiography at some point replacing the need for surgeons or surgery?
That is really the most important question. And I think, yes, this is the way we have to go, together. To produce evidence, if you saw last slides, I was making the evidence that we have to compare the value in any kind of innovations in emergency department that are two objective, patient outcome and cost related. So if we are going, as you said, to demonstrate that we can reduce surgeon length of stay and mortality due to therapeutic angiography, we are going to get the goal. And this is possible only with emergency physician skills in this topic.
Now, how many people want angiography in their emergency department?
I want. Thank you.
Okay, I want to invite with my pleasure. He is chairman of from Stanford University, chairman of Emergency Medicine Department, and he's very popular in Turkey, if you remember from last Congress. And I think he has very excellent textbook of emergency medicine in United States. He will talk about retrograde intubation. Mr. Mahadevan, with my pleasure.
Good afternoon, everyone. How are you? Good, good. It's great to be here. Instead of retrograde intubation, spoke with Dr. Chandler about talking about video laryngoscopy, so I'm going to focus on that today. And first, oops. Get my let's just do one thing. Okay, good. Let's try again now. There we go. Sorry. Okay. Just want to show you where I'm from. I'm from Stanford University, which is in the United States in California. So yesterday, approximately yesterday, 24 hours ago, my wife and I were there at that star right here. And now we're obviously in beautiful Antalya. And I just want to say this is my 5th visit to Turkey and love it here. I've been to Istanbul, Kayseri, Izmir, Konya, Çatalhöyük, and now this is my 2nd visit to Antalya, and I had the pleasure of attending a prior Congress, also getting to sing on stage. Hopefully I don't do that today and scare everyone away, and spend time with Bashar, which is always fantastic. In my talk today on video laryngoscopy, I'm going to define what it is. I'm going to talk about the different classes, the different kinds of video laryngoscopes, the advantages and disadvantages of this new device, and then most importantly, the current literature about video laryngoscopy and how it's maybe taking over how we approach airways. Very quickly, show of hands, how many of you are using video laryngoscopes in your department? Okay, fantastic. So quickly, with regards to the definition, video laryngoscopy is indirect laryngoscopy, which means you're not looking directly at the cords, that you're using a digital device, a digital laryngoscope, to show you the vocal cords in the glottis instead of line of sight. And generally, for what we need them for, acute intubations, we're inserting these devices intraorally. And why would we need to do this? Well, our goal is to see the glottis, and that hopefully will help us improve our success with intubation. And ultimately, we want fewer failed intubations. Obviously, we want to reduce our failure rate. So there are 3 big classes of video laryngoscopes. The first is the channeled video laryngoscope, where the endotracheal tube is part of the device or is inserted into the device, and this matches the anatomic curve of your pharynx and allows you to direct it towards the larynx. But unlike the other approaches where you are manipulating the endotracheal tube separately, this is all one device. So if you want to adjust where the endotracheal tube is, you have to adjust the device. And so the other issue with this, as you can see, is it's bulkier. It's larger than some of the other devices. And so if you have someone with a small mouth, it may be difficult to insert it. The next device I want to describe is something called a Macintosh-style video laryngoscope, where the technique is similar to what we're doing with direct laryngoscopy. And in fact, you could either use the video or do direct laryngoscopy. And for this reason, since everyone in the room can see what's going on and you can give advice, it's great for teaching and training institutions. And then finally, the glide scope or glide scope-like devices are acute angle blade video laryngoscopes, where they're really good at showing you the very anterior structures, but if it fails for whatever reason, you cannot convert to direct laryngoscopy where you can see the cord. So let's take a look at this. a glide scope-like device inserted into the pharynx, and then you're looking at the monitor, you're looking at the screen when you're inserting the endotracheal tube, and so you're looking at the monitor but performing the function in the patient's pharynx. So what are the advantages of this approach, video laryngoscopy? Well, first of all, we always struggle when we're doing direct laryngoscopy to line these three axes. There's the oral axis, the pharyngeal axis, and the laryngeal axis. And if you look at this diagram, what you can see is that it's impossible for us to see like this. We need to see, we have that line of sight. And so what we do is we try and get the patient into the sniffing position, as you can see here, and then by using the direct laryngoscopy and just raising their soft tissues, we achieve line of sight. And sometimes it can be very difficult, as you know, to see the glottis. And especially in patients like this. This is a trauma victim where you're not allowed to get the patient into the sniffing position because you're keeping them in the neutral position. And that makes it very difficult to align these axes. And in this particular case, the patient couldn't be intubated with the video or with the direct laryngoscopy. The other advantage in trauma patients specifically is the video laryngoscope can be inserted and manipulated in a way where you don't have to move the patient's head and potentially cause injury. Here's an example of a patient with an inferior anterior C2 fracture, but if we look at their cervical alignment, it's normal. So the spinal cord at this point is doing just fine. But what happens when you try to intubate the patient and you put them in the sniffing position? As you can see, this patient has a complete disruption of the ligaments holding the vertebral column together, and now the bones have moved and impacted potentially the area where the spinal cord is. So the last thing that we want to do is move the patient's vertebral column and potentially cause injury, which could happen in theory with direct laryngoscopy. And then finally, we're looking at a very narrow, small area and trying to insert an endotracheal tube through that area. Well, what if we were able to enlarge it, make it easier to see? And also, more importantly, as a teaching physician, that not only I could see what was going on, but everybody in the room could have confidence that this was being done properly or that we could assist. So those are the advantages of video laryngoscopy. What are some disadvantages? Well, if there's secretions or blood and it gets on the end of the scope, potentially you wouldn't be able to see. Or if the device fails for some reason and that's the only way, that might be an issue. There are a lot of different kinds of devices, so you have to be familiar with all of them, and we're not sure which ones really are the best. And there's no real evidence to tell us this is the best one at this time. And the technique for insertion is different than what we're used to. And it may be more challenging, just in the same way that if I play video games with my son, he's going to beat me every time because I'm not used to playing video games. Learning how to do a new approach may be challenging because you're not doing it under direct visualization. You're holding the device and then trying to look at a screen and perform the technique. And a number of studies have shown that when you're doing it indirectly, it can be more challenging. So now let's go over 5 important studies that might change the way that you think about video laryngoscopy as part of emergency medicine. And the first one to bring a lot of sort of attention to this was this systematic review, Cochrane review, that was done in 2016. This Cochrane review wasn't specifically focused on emergency physicians or critical care physicians, but looking in general at comparing direct laryngoscopy to video laryngoscopy. So they looked at a lot of studies, 64, 7,000 plus adult patients, but again, mostly in the operating theater and not in emergency settings. They compared different kinds of video laryngoscopy to direct laryngoscopy using a Mac blade. And here are the primary findings of the study. There were fewer failed intubations with video laryngoscopy, and this was statistically significant. When dealing with difficult airways, there were fewer failed intubations with video laryngoscopy. And then when they compared the incidence of hypoxemia, it was similar between the two. So, major headlines, bottom line from this large Cochrane review: fewer failed intubations overall, fewer failed intubations when dealing with difficult airways. Next, we decided, since that was a focus on all comers and primarily the operating rooms or operating theaters, what about for those of us that practice outside of the operating room? Well, this systematic review and meta-analysis looked just at those places. So this was 32 studies with over 15,000 intubations. And you can see that there were about 6,300 video intubations and 8,700 direct laryngoscopic intubations. And these studies were outside of the operating theater, outside of the operating room. So they were in the pre-hospital setting. They were in the ICU. They were in the emergency department, places that we practice. And again, they use different kinds of video laryngoscopes as opposed to just one kind, and multiple kinds of providers. So there were beginners, there were experts, there were paramedics, there were emergency physicians, there were ICU doctors. So a whole mix of different kinds of providers. And what they were interested in is, how often do you succeed intubating the patient the first time that you try? So let's take a look and see what they found. With regards to first pass intubation, there was no overall difference in this study between video laryngoscopy and direct laryngoscopy. However, if you were in the ICU, video laryngoscopes were better, but if you were in the emergency department or pre-hospital area, they were similar. What about the glide scope, which is one kind of video laryngoscope, and direct laryngoscopy? Well, they were similar. But when the CMAC, a specific kind of video laryngoscope that allows both direct and indirect laryngoscopy, was compared to direct laryngoscopy, it was better in terms of getting that first pass intubation. If you were a novice or a trainee, video laryngoscopes were better. But if you were experienced or a paramedic, it was the same. And then with video laryngoscopy, there were fewer esophageal intubations and more arterial hypotension. So what are the big takeaways from this study of non-operating theater, of emergency situations, ICUs, emergency departments, pre-hospital? Well, if you're in an ICU, video laryngoscopy was better. CMAC was better than direct laryngoscopy overall. And that if you were a novice or a trainee, that video laryngoscopy was better, and that there were fewer esophageal intubations. One of the themes that you're seeing here is that in many cases, in different facets, it's better, but it's never worse. And that's a very important thing as we move forward. Finally, I want to look at a study that it was a systematic review and another meta-analysis, but this time they looked at difficult airways and experienced providers. So most of you are experienced providers, and all of us that practice emergency medicine have had a difficult airway. And one of the things I think we can all tell you is, though we try and figure out who might have a difficult airway, sometimes it's very difficult to predict. And in this study, published in Anesthesia in 2015, of patients going to the operating room, the anesthetist could not predict a difficult intubation 93% of the time. They could not predict a difficult patient to mass ventilate 94% of the time, which tells us all of those tools and rules that we have don't work very well, and that any intubation could be a difficult intubation or a difficult airway. So in this study, which looked at experts and difficult airways, how did video laryngoscopy do? Well, it was better for first attempt at success, and you can see on average, when using a video laryngoscope, 95% of the time you were successful the first time versus 86% with direct laryngoscopy. And you got better views of the glottis and less trauma to the airway overall. So again, the take-homes, we're talking about experienced providers, difficult airways, and video laryngoscopy perform better. So it begs the question, and this was an editorial that was in the British Journal of Anesthesia, about whether we should be using video laryngoscopy as the first approach all the time. And here's the analogy that they used. They basically said, how many of you still have a huge bulky cell phone like you did in 1995? None of us, right? We're all using some kind of iPhone or new phone equivalent, and none of us are using dial-up phones either. So as technology progresses, why are we relying on old technology when new technology is potentially superior? And they went one step further. They said it should be used on every intubation, and that we should record the video and put it in the medical record so that if the patient ever came back, they could review the video and determine if there was an airway problem or not. 2 more studies to review before I finish. This is a group of anesthesiologists that decided to replace all of their direct laryngoscopy with video laryngoscopy. So I'm going to show you what happened. First, they assessed all of their team about their attitudes towards video laryngoscopy. And then for 2 months, they removed all the Mac blades from their operating room and from the places where they worked, and they only had CMACs there, okay? Which CMACs where you can do video laryngoscopy and direct laryngoscopy if you needed to. And then they did serial assessments over a course of time to see what attitudes were by the anesthesiologists towards video laryngoscopy. So here's what they found. When they started, about a third, and a third either said we fully support only video laryngoscopes, or we have some reservations, or some people said they don't support it. At the end of the trial, the 2 months of just using video laryngoscopes, there were fewer people that didn't support, but it certainly didn't have unanimous support. 6 months later, you can see a lot more of the anesthesiologists supported it. And then 18 months later, uniformly, everybody in their department supported having only video laryngoscopy. And the reason that they said was they felt it was better for patient safety, team dynamics, human factors, quality of care, and quality of training. So they changed after being forced to use them for a period of time. Their attitudes totally changed. And for many of us, it's the same. We're so used to direct laryngoscopy, we don't want to change, even though it might be good for us. And the last study I want to show you is one that's done in the pre-hospital setting, where they looked at a protocol where they used the CMAC, again, this video laryngoscope, and a bougie in all rapid sequence intubations. And so this was done in Finland, where for a period of time, they said you're going to use video laryngoscopy and a bougie, in particular it was a Frova introducer for all intubations. And then they compared that 22 months where they were doing that to the year before where you were able to do direct laryngoscopy. And here's what they found. Before using video laryngoscopy and the bougie, the first pass success rate was 85.7%. After being forced to use this protocol, using the bougie and the video laryngoscope, it increased to 98.2%. And think about it, intubating, doing RSI in a helicopter is a difficult airway situation. And here they went all the way up to 98%. And it begs the question, we always think of video laryngoscopy as a rescue device or difficult airway device, but what if we used it routinely? What if we used difficult airway devices routinely? We can see that we would have an increased success rate, which we all want, and that, again, a bougie may be easier to pass with a video laryngoscope than an endotracheal tube. So a couple of takeaways from this study. So finally, what do we know? What's the bottom line? What can we say about video laryngoscopy? It improves the view of the glottis. It may improve first attempt intubation success rate. Remember the study I reviewed from Peters et al., 95% success rate with video laryngoscopy compared to 86% for direct laryngoscopy. The Cochrane review found that it may reduce the number of failed intubations. Again, fewer failed intubations when for overall and also when dealing with difficult airways. We know that it's already become part of our difficult airway algorithm, but it may be the primary approach for all intubations in the near future. And if you're using a device like I like, and I don't have any ties or affiliations with stores or the CMAC, but a device like CMAC, which allows you both direct and video laryngoscopy, is a device that might allow you to embrace the future without abandoning the past. And so those are my big takeaways about video laryngoscopy. And I want to thank you for your attention. Thank you very much.
Thank you very much, Dr. Madem, for fantastic presentation. Any comment or question? Yes, please.
First of all, welcome to Turkey and thank you for your presentation. I want to ask that I work in a hospital where approximately 1,000 patients apply per day. And I think that means that we manage disaster every day. And in my country, there are so many centers. While we are examining the cold or myalgia, on the other side, we may need to intubate the patients. And I think it's more difficult about us. What do you think about the practicality of this process in crowded emergency departments? Thank you.
Thank you for your question. I believe the question is that in settings where maybe you have less experienced providers, are crowded, what about having a device like this in those settings? And I think, you know, it's, the studies pointed out, those who are less experienced with intubating actually showed the greatest benefit in first pass success. And so it probably behooves us, if you're intubating all the time, you might have some expertise, but if it's an infrequent procedure, having a video laryngoscope might be of benefit, especially if you're doing it infrequently. But the other study I showed also revealed that even in experienced hands, it's hard to know when we're going to encounter a difficult airway. So rather than take a chance, my feeling is that we are progressing towards where we'll be using this exclusively, and that direct laryngoscopy will be something of the past.
Okay, thank you very much. Any another question?
Yeah, here, yeah. Okay.
Okay.
No, Basar, I have a question.
Okay.
Thank you very much for this nice presentation. And it's clear we have the evidence for using this kind of tools. My question is, do you have information about the cost? You know, if you compare CMAC to the direct, laryngoscopy, this is very important, for different countries in the world.
So the question was a very good one, which is it fiscally responsible to replace a device that may be working with something that may be more expensive? There's two ways of looking at it. If you already are adding a device like a CMAC as a rescue device, then you're already purchasing it anyway in addition to the direct laryngoscopes. And the other one is more philosophical, which is that if your complication rate goes down and you have one less patient who has anoxia as a result of a difficult airway encounter, and the hospital isn't sued or doesn't lose money as a result, or the family doesn't lose money as a result, then that could justify, that cost savings from fewer complications could easily justify the cost difference between a laryngoscope and a video laryngoscope.
Okay, thank you very much. Last question, please. Last question. Yes.
And thank you very much for your presentation. I will ask, you said that some kind of video laryngoscopy is better than direct laryngoscopy in difficult intubation. But was it expected, difficult intubation, or unexpected, or was it well-designed criteria?
In the study that I presented, it was anesthesiologists who predicted a difficult airway based on patient characteristics or prior knowledge. And in that case, video laryngoscopy was more effective, even though they were experienced. But there was one study that I presented also that just shows we are not good at figuring out who is going to be a difficult intubation or difficult mask ventilation. And that's the problem. If we could just look at them and say, oh, you've got a beard or you've got a short neck, you're going to be a problem. But we've all encountered somebody that we're really worried about, and then we go in and it's an easy intubation. And we've also had patients where we say, oh, this is going to, they've got a long neck, it's going to be fine, and then you go to try and intubate, and it's much more challenging. And so it's just, we don't have good tools. And we should just, basically, my feeling is approach every patient like they're going to be a difficult intubation. Thank you again for your question, and thank you for your attention. Thank you.
Thank you. The next speaker, it's a very important topic for emergency medicine, new topic. Reboa in ED, Dr. Yosuke Matsumura from Japan. Thank you.
肺結性 E 群らベニムアディムヨスケ松村ジャポニアダンゲティム I'm a emergency medicine physician, and I also cover the ICU. And my another subspecialization is endovascular therapy. I cover the interventional radiology and of course rebore, and I also love to perform ECMO. So I am very interested to be here. Thank you for having me. So here's my disclosure. So let me introduce some rebore practice in Japan. So this is the procedure video. The first thing you need to do is get the access. The access at the common femoral artery. You need to puncture between inguinal ligament and bifurcation. Of course, you should use ultrasound routinely. You can see the bifurcation directly. And you advance the guide wire to the aorta. Then remove the needle and insert the arterial sheath over the guide wire. Then you can put the rebore over the guide wire. In this setting, the balloon is going up to zone 1. And next step, you need to exchange the guide wire for a stiff wire. This stiff wire will strengthen the shaft of the catheter. Then, then you can inflate the balloon. So by the way, the term reborn was published in Journal of Trauma in 2011. But in Japan, we start to use reborn catheter in 1998. So we have a very long history. Oh, sorry. But unfortunately, we didn't publish a lot of research paper in this field. 2003, 2009, 2015. Sorry about such long silence. Only small case series were published from Japan until 2015. But in this year, one case series was published in Journal of Trauma. The title is Safety and Feasibility. But I need to give a question to this paper because they reported the rate of lower limb amputation at over 20%. Surprising number. Next year, another paper was published. This is a database analysis using a propensity score match analysis. And they reported higher in-hospital mortality in reward group. This is negative data from Japan. A similar study was published very recently in JAMA surgery from the United States. This is again propensity score matching. And they reported higher rate of AKI, amputation, and high 24-hour mortality in reward group. So lower limb amputation. These two studies, the research period was before 7 French reward device. In the United States, they used to use 12 French, and in Japan, we used to use 10 French catheter. But now, we have 7 French small profile reward catheter. So probably this problem can be solved with such small profile catheter. This is our publication. So we demonstrated the fewer complications in small sheaths. We didn't require any fasciotomy, amputation, or PTA. But what about higher mortality? How should we use reward? One possible answer is here, algorithm. This is a classical algorithm suggested by Shock Trauma Center in the United States. And this is another algorithm from the Denver. This is another algorithm presented in the Western Trauma Society. How many reward algorithms do we have to learn? I hate to memorize many things. I believe to learn trauma strategy is more important to learn algorithm. So this is the summary of today's my talk. The first is thoracotomy plus reward can be the good solution in a critically ill patient. And second is early access, undelayed but short occlusion. These are the key issues for the successful management of reward. And third, I'm going to mention the education and research briefly. So let me introduce our recent case. 17-year-old boy, he fell from 11th story of the building. Actually, he jumped from the building. He collapsed 5 minutes before arrival, and CPR was initiated by the EMT. So first, we performed resuscitative thoracotomy and LD cross clamp. And he was resuscitated after 8 minutes of the CPR, and chest X-ray didn't show any significant injury. And the fast exam was negative, and pelvis showed the fracture. So I identified the cause of the shock was here. So we got bilateral arterial access and the large venous access, and the massive transfusion was initiated. Then the fast turned positive at right upper quadrant. So I decided to go to laparotomy first. Can you see this picture? Before going to the operating room, we converted thoracotomy to zone 1 rebore. And the patient was transported with partial rebore. And in the operation room, we could deflate the rebore within 20 minutes, and the surgeon found a liver injury. But it was not so severe, and fortunately, no other organ injury was found. Instead, retroperitoneal hematoma was expanding rapidly, and so the surgeon simply performed perihepatic packing, and abdomen was left open. And next, this is my turn. I embolized bilateral internal iliac artery approximately within 10 minutes. And now, we didn't see apparent extravasation in this patient. Now we scanned the patient, but we found a chest wall bleeding. So we reclosed the chest wall in the ICU. So first, the thoracotomy plus rebore. So we performed thoracotomy first, then converted rebore. So this is a comparison between thoracotomy and rebore. The thoracotomy is absolutely more speedy and definite, but we need to make new chest wound, and sometimes the chest wall bleeding is significant, and thoracotomy may induce hypothermia. The rebore is less invasive and adjustable, but we need to puncture the common femoral artery. Sometimes this is troublesome, and the patient has a leg ischemia. So this, in Japanese educational course, we suggest this strategy. If the patient is impending cardiac arrest, or if the patient doesn't have arterial access, don't hesitate to do thoracotomy. But if the patient is shock but not cardiac arrest, and the patient has the arterial access, consider the rebore. This is a comparison between thoracotomy versus rebore. So one study showed the benefit in rebore, and the other did not. This is a study from the United States. They concluded rebore has a benefit in selected patient. What is a select patient? It means no CPR, but hypotension at arrival. But do we have to compare thoracotomy versus rebore? My answer is no. We can perform these two aortic occlusion methods in one patient. I know thoracotomy is not strongly recommended in post-stress blunt trauma patient. And of the 106 trauma rebore patients, we experienced